Excuse me.
What about for sons? I heart football.
I heart New York.
I heart racing to set meat in a can. And I heart race.
Love those guys. What a great sound. All right, welcome back, guys. We are doing special senses today, okay? First of all, are there any questions before we get started? Okay, no questions? Okay, so last time we met, we did autonomic nervous system, which is comprised of two major parts, right? Okay, sympathetic and parasympathetic. Sympathetic will be fight or flight. Parasympathetic will be calm, relaxed, and rejuvenating, okay? Sympathetic begins, or some mnemonics that we have to help us remember begin with the E. Exercise, excitement, and embarrassment. That's what kicks into play when we feel those emotions. Parasympathetic will be when we digest, diuresis, and defecation, okay? They balance each other. It's not good to be in one extreme or the other, okay? Now, we went over the innervation, where the nerves go, how there's two nerves with a ganglia in between, which one has the shorter in the beginning, which has the shorter in the end. Review all that. It's all good stuff to review, okay? And that's a general gist with the autonomic nervous system. It's also part of the peripheral nervous system, and it's automatic. It just happens by itself, okay? Is that all ringing a bell? Okay. So, today we're going to move on to special senses, and a lot of this we touched upon in lab. So it should sound familiar, which is a good thing, okay? A little bit of review. So chemical senses, taste and smell, also known as gustation and olfaction. So people at home, let me bring in, because I have a lot of pictures that I want you to check out here. Okay, taste buds. We went over the 3 types of taste buds in lab. This should all be pretty self-explanatory. There's circumvallate. Are these in here? I don't have them down. Okay. Circumvallate, filiform, and fungiform. Okay, circumvallate, filiform, and fungiform. Circumvallate. I think your book also references this as just vallate. And then we have filiform and fungiform. Okay. Circumvallate, there are 10 to 12 large, and they're on the posterior of the tongue. I'll take it back to a picture in just a second. Okay. Fungiform look like little mushrooms. And if you look on the surface of your tongue, you can see slightly enlarged little round circles. Those are fungiform. The rest of the tongue is covered with filiform. And they're a little more sharper looking. I mean, they're not pointy, obviously, but sharper looking. And that's what gives us the friction on the tongue. When we look at the cat's tongue in GI next semester, I believe it is, when you feel, or if you have a cat at home, people are smiling a little bit. Cat at home, the surface of their tongue is rough, isn't it? Okay, and that's because their filiform are very pointy, and it actually helps them to clean themselves, that roughness, okay? So filiform has a little bit sharper of an appearance, and it's create kind of that carpety appearance to the tongue. Now, which two have taste buds? Okay, so circumvallate and fungiform both have taste buds. So if we take those little circles off the tongue and we look at the surface of them, you know, so if you imagine fungiform looks like that as you're looking down on top of it. If you look at it from the side, that's what it looks like. it's got little pores on the sides. And those little pores are areas that we can taste our food. Okay, those taste buds. So that's all pretty easy. That should be a good review for us, right? So let me ask you guys, think back to epithelium. Why does a burnt tongue heal so well? Thinking back, does everybody have this? Yeah. Why does a burnt tongue heal so well? It's because it's covered, the tongue is covered with the stratified squamous. And stratified squamous, I just did this. I stopped. I've been craving that mint chocolate cocoa from Dunkin' Donuts. It's delicious. And I got it, and I don't know what I was thinking. I just took a big swig, right? And I felt immediately, isn't that like the worst feeling? You're like, do I spit it out? What do I do? Right? You know, covers my mouth, down my throat. Well, within a day, it felt better because it has stratified squamous on it. And not only does it have stratified squamous, those areas of the body are highly mitotic because of that reasoning. Okay, because there's a lot of friction and food intake in our mouth, we need to be able to regenerate that quickly. So that's why that regenerates and heals so quickly, because it's covered with stratified squamous. Now, that whole, did you ever hear of the taste mapping, you know, where you taste different? It's not true, okay? Different taste buds on, it's just not true. You taste it throughout the tongue, okay? There's different receptors on each of those little papillae that'll sense those different tastes. But the taste that we taste, I've listed there. We have sweet, salty, sour, bitter, and umami. I know it sounds really weird, doesn't it? Umami. It's like your mommy, umami. Umami, guys, is a very savory. If you think of like a steak or Worcestershire sauce or steak sauce, that's what umami is. And they actually found the reason that we have these different taste descriptions is there's specific taste buds that sense these specific tastes. Okay, so, and then there's no tongue mapping. That's what they reference. I know you're going to hear that different in other places. Numerous research says they don't have that. So, okay, physiology of taste. So which cranial nerve is going to sense taste? There's actually two. I want you to know the main one. Very good. Facial. Okay, facial is going to actually create or receive the sensation of taste from the anterior 2/3 of the tongue. Okay, facial. So there's these little nerve receptors in the tongue. Those send messages to the facial nerve. Okay, also glossopharyngeal if you want to know that. But primary one I want you to know is facial. That signal will be sent, okay, to the medulla. It'll cross over to the opposite side of the brain at the medulla. That's where everything crosses over. It'll go to the thalamus, okay? And then thalamus does what? Roots at all the different places of the brain. Remember that? Does anybody remember where taste is sensed in the brain? Okay. Yeah, parietal, temporal lobe, somewhere right in this area. Okay, parietal, actually between them, parietal and temporal lobes. Okay, any questions about that neurology of that? Pretty straightforward. Let me ask you guys this. Why does bitter have a really low threshold? So what does a low threshold means? Doesn't take much to stimulate those taste receptors. Okay. Why does bitter have a low threshold? It's a survival thing because many what taste bitter? Poisonous things. So we've actually sort of lost that affinity for, and I don't mean bitter like black coffee. I mean like bitter. Like you can imagine like a poison tasting or, you know what I mean? Like bitter. Do you ever do that taste test, right? Where you taste, or there's tasters and non-tasters in genetics? No, you guys didn't do that? There's this little strip, and if you taste it and you have the gene for this tasting, it's bitter. And if you don't, it doesn't taste bitter to you. But anyway, that's bitter. So bitter has a low threshold because a lot of times really bitter things are poisonous. So over time, we've lost that affinity, right? Because what happened to cavemen who liked those bitter plants that were poisonous? They died, right? And they didn't pass on those genes, right? Well, that's, I always think that a lot. Like, what would happen if we were just dumped in the middle of a forest? Would you guys know what to eat? Like, how did people find out what was good to eat and what wasn't? They just tried stuff. They were hungry. They ate stuff, and they found out over time. I would be lost. I'd eat probably the poisonous mushroom. So it was trial and error there for a while. Now, olfaction. So what we're looking at here is a little section through the roof of your nasal cavity. That's what we're looking at here. The thing to keep in mind, guys, is that the nerves that sense smell are directly open to the brain. It's the only nerve that's like that. This is actually one of the theoretical areas that we can get meningitis. Eek. Okay, you get those infectious organisms that are airborne. They go into your nasal cavity, they attach to the olfactory nerve, and they start to move up it and into it. Okay? So you can see that it's the only area, and you can see them. They're exposed, and they go right up through what's called the ethmoid bone. So you can see that nasal cavity. They have a little section. They've pulled it out, and we're going to look at that little section there, okay? So we've got these little receptors are the yellow structures. So those are actually going to be the receptors for the sense of smell. They'll bring that signal. They'll send it up to what's called the olfactory bulb, which is that round portion in the front of the olfactory nerve. Okay, that has the cell bodies, and then the axons are going to form that olfactory tract that goes back to the brain. Are you with me? Can you visualize that in your brains as I'm talking about it? Okay, so you could see also, I want to point out two other things. Around those little yellow receptors that are bringing in that sense of smell, we have purple cells as well. Okay. The reason those are supporting cells, they're epithelial cells. And the reason I want to point those out is that surrounding those, we actually have stem cells that they're starting to take little pieces of. And what are stem cells used for? Research. Because some cells are undifferentiated cells that can be turned into any cells. And the reason that we've had difficulty harvesting them is the best area up until recently to get them is fetuses, right? Aborted fetuses. So what they're finding is they're starting to harvest some of these cells from the nasal cavity, and they can use them as stem cells. Isn't that cool? Okay. So just to point that out. So there's also these little mitral cells. I just want to point those out because I'm going to explain something to you in just a second about those mitral cells. Okay, so smell comes in, stimulates those receptors, goes to the second nerve, which is going to be in that olfactory nerve. It's going to go back to the brain. Yes? No? Okay. So they're replaced every 40 days. That's the reason we have stem cells there, because they're highly regenerative. These are also the only nerves that regenerate in the body. They actually get destroyed and regenerated because those stem cells are there to help replace them. Are you with me? Right? Which is kind of an interesting concept as well. So obviously smell has to be in a gaseous state. That makes sense. Okay? So these neurons are replaced every 40 days. It's only here in the body that this happens. So these mitral cells are going to start that second order neuron, that second part. Now, long time ago, gosh, going on 7, 8 years ago, we went up to my father-in-law's camp. He has a camp at the St. Lawrence River. And he's well into his 70s at this point. And we walk in, and there's a god-awful smell in his camp. You know, he just opened it, like the season's opening or whatever. And we're like, what died in here? Like, did you ever, like, smell a dead animal? Like, that, yeah, it had that real gamey. And he's like, what are you talking about? Like, I don't smell anything. Because his olfactory nerves don't work well. Well, anyway, we were going to spend the night there. and it was freezing outside. We're outside. I'm trying to stay out away from this whatever smell is. And finally, after a while, I'm like, it's just too cold. It's like 30 degrees. I'm going inside. Well, after like half an hour, I'm like, I don't smell a thing. Let me tell you why. Because those mitral cells can actually inhibit the sense of smell after a while. You get used to it. Do you still smell your perfume after you put it on? No, you get used to it. Those olfactory receptors turn off. Okay, and that's where that happens at that second order neuron. Well, it turns out we left, the next day or whatever, and he found a dead raccoon under his bed. Oh. He's like, oh, you were right. Like, he thought we were crazy and just being like, yeah. But strong signals will override this. So if a skunk had gone by, my olfactory receptors would have turned back on. But after a while, they get turned off. Yeah, that was pretty foul. Sorry. Sorry, Dad Art. Olfactory pathways. Okay, we went through this already. But the thing that I do want to point out is that it goes to the frontal lobe. That's where we sense smell. But we also send those signals to the limbic system. And what does the limbic system do again? It helps to monitor or control our emotions, okay? And I think I've given this example before. Do you ever walk by somebody who has a cologne or perfume on that your ex used to wear? Right? What comes right into your mind? That ex-boyfriend or girlfriend. Hamburgers. When I do hamburgers, that always reminds me of my grandmother because I'd spend the night with her on Saturdays and she'd make me hamburgers, when you fry them on the grill. So there's that direct connection, and it really stimulates those emotive responses. Very strong connection. Okay? I envision. So why are your eyebrows not 10 inches long? Thank goodness. Although some people's get pretty long, don't they? Yeah. They can. Why are eyebrows not 10 inches long? Why does your head hair could grow as long as your knees? Yeah, because the lifespan's different. Very good. The lifespan of the hair that grows above the eyes is much shorter than the hair that grows in your head. Okay? Above the eyes is just a couple months. I think I have the exact numbers a little bit further ahead. Your head hair can grow for 10 years. Okay? That's why it can grow so long. And isn't that nice, right? Because if your eyebrows kept growing or your eyelashes kept growing, that'd be a little weird. So we've accommodated over time. And it's important to have hair in those locations. It actually helps to shelter our eyes and protect them. Obviously, that's obvious with eyelashes and also with eyebrows, okay? But we don't need it to be really long or it would be in the way. It'd be a little creepy. Palpebrae are the eyelids. That's another word for the eyelids. And we need to know those structures. And I put a little picture up there to review. Let's see, we've talked about conjunctiva. I want you to look at the conjunctiva on that bottom picture. The conjunctiva, guys, is a very thin membrane. And it actually starts on the inside. You guys might not be able to see it in class very well. But when you get a chance to look at this at home or in your book, I think this is a good picture to review. Okay, the conjunctiva starts on the upper eyelid, goes all along the upper eyelid, and then down onto the eye. So it kind of folds like this. Okay, so if this is the eyeball, I told you guys I can't draw, right? Like at all. So I'll do the best that I can. Here's an eyelid. Here's an eyelid. The way that the conjunctiva, this is clinically important, that's why I want to draw a picture of this, comes on the upper eyelid and then takes a turn, comes down and it stops before the cornea, and then the same thing happens at the bottom. The reason that that's important is because when you go to put eye medication in, it creates a nice little pocket. You can just pull the eyelid out and drop the eye medication in, and it'll wash over the whole eye. Because that mucous membrane, that conjunctiva, creates a nice self-contained little pocket in the eye, okay, that helps to protect it, okay? Palpebral fissures are going to be those indentations, okay? Eyelashes, that's obvious. That's called the conjunctival sac. I'm reading through these things. Cornea is going to be the surface of the eye. Little tarsal glands, you can see that picture there. We're going to actually talk about those in just a second. Tarsal plate, you don't need to worry about. Eyebrow, yeah, that covers most of them. Okay, yep, that covers most of the structures. Now that tarsal plate are going to be glands that will find people at home. Let me bring you in. Okay, in the upper eyelid, they can get infected. Okay, they're called chalazions, and they get infected. Okay, and they can't secrete They secrete like a mucousy, oily substance that helps to lubricate the eye lashes. And if they get infected, they get blocked, okay? And there's not a whole ton that you can do for this. A lot of times they tell you to do hot compresses. I guess if it gets really bad, they'll do antibiotics. But you can imagine that'd be pretty painful, right? Okay. So chalazion, tarsal plate infection. Now, a sty is going to be right where the eyelashes come out, okay? Right where the eyelashes are, there's little oil glands that connect to those eyelashes that will help to lubricate the eyelash. And so the sty, as opposed to being in the eyelid itself, a sty will be right at the base of one of those openings for the eyelash, okay? That's also uncomfortable as well. I think you'll see that more frequently than you'll see a chalazion. If you go into clinical practice, I think that's a little more common. So conjunctiva, we've got what's called palpebral and ocular. Remember I drew that little picture. The part that touches the eyelids is called palpebral conjunctiva. The part that touches the sclera is called ocular, okay? But yes, the part that covers the eyelid or lines the inside of the eyelid, maybe it'll help if I point to this picture. So this part is called palpebral, it's touching the eyelid of the conjunctiva. This part is called ocular. Okay. Palpebral and ocular. And this will be the conjunctival sac in which you could put medication. I know that some people, when they administer eye meds, they'll just drop it right into the eye. I think it's really nice to put it, you just pull the bottom eyelid out and put it in there. I hate it when people drop drops right into my eyes. It drives me nuts. Like a weird eye thing. So, okay, so you can administer that medication right in there. So this part is palpebral. This part is ocular, that's on the eye itself. Okay, and this would be palpebral as well, and this would be ocular as well. And then this would be the little conjunctival sac that you could administer eye medication into. Does that make sense? Is that good? Okay. Now, conjunctivitis, do I have that in there? Well, conjunctivitis, I guess I don't. I guess because I cover it in lab. Sorry, I hope I'm not making you dizzy. So conjunctivitis obviously is going to be an inflammation of that. If I could give you a little bit of advice, never put Visine into an eye that has conjunctivitis. It makes to secrete copious amounts of mucus. What does copious mean? Lots. Found that out by experience. If you have conjunctivitis, you've got to get an antibiotic to put in. Okay, there's drops for kids, or also there's like a little gel cream that you can put in there. The thing about conjunctivitis too is it is highly, highly, highly contagious. Okay, so if it starts in kindergarten, it's probably going to go through most of the kids. Okay, it's very contagious. Any questions so far? We're good? Excellent. Lacrimal apparatus. This should be pretty easy. We went over this in lab. There we go. Okay. Lacrimal apparatus is going to create this saline solution with some antibodies. It means it fights some infection because once again we're just going to start talking about this. The surface of our skin, the surface of our mucous membranes, the surface of our eye, we are fighting contagions all the time, antigens, infectious agents all the time. So we have what I call front lines of defense, things that we have in place to fight off those infectious agents. Okay, so we actually have substances that are secreted in that saline called antibodies that help, and also enzymes called lysozymes to destroy bacteria when they come into place with them or into contact with them. Okay. So this is a great picture. You can see that lacrimal gland saline, or tears, I should say, because it's more than just saline, will wash across the eye and go through that lacrimal puncta. It'll drain through the nasal lacrimal duct and then into the nasal cavity. And we went through that in lab. Any questions about that? Now, punctal plugs are going to be these little plugs, and this happens most often when people have that laser surgery, that eye surgery. One of the nasty, nasty side effects is they get extremely dry eyes. I don't know the mechanisms behind it. Maybe it's because they irritate the surface of the cornea. Do you guys know what they do with the laser surgery? They actually shave the cornea down. Okay. And maybe it's that shaving that causes a reaction that creates dry eye. I'm not sure. But they get dry eye, and one of the treatments is they could put little plugs into those puncta, okay, to keep those tears back in the eye and try to keep it as moist as possible. It's one of the main reasons I won't get that laser surgery. It kind of freaks me out. A lot of people do well with it, but I don't know. I get nervous. There's another surgery that they're doing, actually. I'm sort of waiting on this one, where they'll go in and they actually replace the lens. So instead of shaving that cornea, they take the lens out and they replace it. Well, it sounds funky, but guess what a cataract surgery is? They take out the lens and they replace it. How many people do you know have had, well, maybe you guys don't, but a lot of people have cataracts. Now that I'm getting older, I know a lot of people have it. Not my age, but a little bit older. Cataract surgery is very successful. So the surgeons that do that cataract surgery, guess what they're starting to do? Replace the lens. And the cool thing then is you don't have to have cataract surgery in the future, and you don't get cataracts. So it's pretty cool. Okay. So extraocular eye muscles. This should be easy. Do we need to review this? Okay. We've got the 4 rectus muscles. We've got the 2 oblique muscles. If you don't remember this, please review it from lab. Do we need to review this? No? Okay. No? I'll just do a quick review. If you need a review, it's in lab, or you can come see me. 4 rectus muscles are going to pull the eye in the direction they're named. Superior, inferior, medial, lateral will pull the eye. Superior, medial, inferior, lateral. Okay? Oblique muscles both move the eye laterally, but opposite their name. So superior oblique is going to move the eye laterally, but down. Okay. Inferior oblique is going to move the eye laterally, but up. Superior oblique's nerve is going to be cranial nerve 4. Lateral rectus is cranial nerve 6. The rest of the extraocular eye muscles are innervated by cranial nerve 3. Okay, this is all from lab. So if you don't remember it, just see me. Do you need me to review any of that or say it again? Good? Okay. So eye movements, innervation, you definitely need to know this. So if you don't remember it, look it up in lab or come see me. I'd be happy to help you. Now you can see on this picture, this is a great picture because all those muscles come back to a common tendon. Okay, they all come back to a common tendon that helps to secure it. This is also a great picture to see the superior oblique. If you look at the picture on the right, you can see the completion of that superior oblique and how it comes up across the top of the eye and makes a little turn. Okay. And then you could also see on the lateral view, you can see a nice little picture of that inferior oblique and how it comes across the eye. What's the name of cranial nerve 4 again? Trochlear? Well, isn't that interesting that superior oblique is innervated by trochlear, but it also goes through what's called a trochlea, which is a little anchor that helps to hold it in place. Can you see that on the picture? Can you guys read that? Okay, that creates that angle. And it helps to create that angle so we can move the eye in those different directions. Okay? Good. Diplopia is going to be double vision. Okay, double vision can happen from a couple of things. One of the things that can cause double vision is strabismus. We touched upon this in lab. Strabismus is going to be weakness of one of the rectus muscles, lateral or medial, that can cause the eyes not to be aligned with each other anymore, right? So you can get weak eye muscles, usually lateral or medial rectus, and then the eyes can drift, okay? So if we have weakness of the lateral rectus muscle, how is the eye going to drift? If we have weakness of the lateral rectus, will the eye drift up, down, in, out? What do you think? What does the lateral rectus do? How does it move the eye? It pulls it laterally. So we're going to lose the ability to pull it laterally, so the eye will drift in medially. Are you with me? Because it can't pull it laterally. If the medial rectus is weak, we can't pull the eye medially, so the eye will drift laterally. Are you with me? Do you need me to explain that again? That's kind of important to know because you'll see this. I saw this with my daughter. My daughter is 14 now. She has I forget the exact numbers, but it's something like in the left eye, her vision is 20/200, which is like what I have. So if I take my glasses off, I could see you guys. I couldn't read the clock. I couldn't read the TV. It's not horrible, but it's not great. Her right eye is 20/1,000. It's much weaker, okay? So what happened to her is it's not strabismus. She actually got, and this is what I'm going through, a lazy eye, okay? So what happens is her brain senses her left eye is stronger in vision. So guess what it does? It starts to ignore the right eye and it starts to drift. Just kind of turns it off. It's called a lazy eye. So what they do, and this is probably one of the most common things you see with this diplopia, because that's what she was getting. Her eye was drifting in, okay? She was getting that double vision because her eye would drift in. So what they do is they'll patch the good eye and they make the bad eye work, and it strengthens it and it keeps those rectus muscles strong so it doesn't drift, okay? So lazy eye is one thing. Strabismus is actual weakness to those extraocular eye muscles, okay? So you can strengthen those with exercises, but they can also do surgery for that as well, okay? And correct the problem. Okay, so diplopia. Any questions on that? The diplopia is going to be the double vision that's a byproduct of either the weakness or the lazy eye. Okay. So structures, this should be pretty straightforward. I'm going to kind of zip through this. We've got those three layers. We've got fibrous tunic, vascular tunic, and nervous tunic. So fibrous is going to be where? On the outside or the inside? Outside. The middle layer is going to be the vascular layer. The inner layer is going to be the nervous layer. Okay. Fibrous tunic is sclera and cornea. I'm going to zip it through this because we should know this. Vascular tunic is going to be choroid, ciliary body. You know what? I want you to basically focus on, well, no, we'll go through those. Choroid and ciliary body, I'll show you a picture in just a minute. Suspensory ligaments, iris, and pupil, okay? Iris is the colored part. Sensory tunic is going to be the retina, optic disc, rods, and cones, all the nerve parts. We're going to go through these, okay? At least I think, do I have separate? I don't. Okay, we'll go through them now. Thought I had notes about this. So the choroid and the ciliary body. So the choroid is going to be the majority of that back part of that vascular layer, right? Actually, let's look at a little picture here, okay? So if we were to take the retina off, the bulk of that vascular layer is made up by choroid, okay? That's on the previous. You might want to stay on the notes that we were just on while I show this to you on the picture, okay? As it gets closer to the front part, we have what are called ciliary bodies. Those ciliary bodies and suspensory ligaments, guys, connect to the iris and the lens. The ciliary body are little muscles. Okay, so we're still talking about the vascular layer. In the back part of the vascular layer, the majority of that vascular portion is the choroid. As it gets closer to the front, you could see this on the picture, we have what are called ciliary bodies. Those ciliary bodies connect to suspensory ligaments that attach to both the lens and the iris. These suspensory ligaments in these ciliary bodies will either constrict or relax, and that'll change the size of the lens in the pupil, right? And if we change the size of the lens in the pupil, what are we doing? We're accommodating for our light and also for our focus. Okay, so the ciliary body suspensory ligaments are very important to help support that change in vision or focus and also light coming in. Okay, you with me? Okay. Any questions on that vascular layer? You with me? Okay. Inside that, we've got the nervous layer. Okay, the nervous layer is going to be comprised of the retina. Now, on the retina, guys, we have cones and rods. On the retina, we have cones and rods. So these cones and rods are the actual nerves that are going to sense the different types of vision coming in. This is probably in the notes further on, but I don't see it. So I want to make sure we got, whoops, well, we can just do this. Okay, so cones and rods. Cones are going to sense color and clear vision. Okay, rods are going to be dimmer light and peripheral vision. Okay, dimmer light and peripheral vision. So as I'm looking straight ahead and I'm looking at the monitor in the back, what is coming directly into my sight and the colors and that real crisp vision is going to be the cones. If I stare straight ahead, anything that I see out here is going to be the rods sensing that. Okay? So your cones are going to sense your color, clear vision. The rods are going to sense that peripheral vision and more dimmer vision. Okay, night vision as well. Okay, so rods and cones. So if we were to look at the back of the eye, there's something called the, do I go into the fovea centralis? Okay. There's something, so if you have that vision coming into the eye, so if we're looking at the eye straight on, okay, there's going to be an area right in the back called the fovea centralis. Okay, the fovea centralis is going to be where the cones are really concentrated. And doesn't that make sense? Because it's where we get that vision coming in that's crisp and clear and right in the center. Okay? So that's where the cones, if the cones are represented by this, are going to be concentrated here. Do you think we still have cones around the outside or the peripheral of the eye? Absolutely. They're just not as concentrated. Okay? And then the macula densa is going to be the area around that. So the fovea centralis and the macula densa are going to be the area where those cones are concentrated. At the opposite respect, the rods are going to be concentrated out here. So does that mean there's no rods on the fovea centralis or the macula? What do you think? There's none there? Yeah, there's a few. Okay. But the most of the concentration is going to be on the outside of the eye. Okay, so we went through fibrous tunic, sclera, and cornea. Continuous posterior with that dura mater. Vascular tunic, we went through choroid, ciliary body, suspensory ligaments, iris, and pupils, just the opening. Iris color is determined by the amount of brown pigment. The less brown pigment you have, the bluer your eyes are, or the lighter your eyes are. The more brown pigment, the darker your eyes are. Okay, my little guy, my 2-year-old, has dark eyes. They look almost black. It's pretty cool. So he's got a strong concentration of that brown pigment. Okay, pigment. Sensory tunic. Okay, we went through retina, optic disc. Optic disc, guys, is going to be where the optic nerve comes in. I knew I skipped something. That's why I was reading through it. Okay, so there's an area on the back of the eye called the optic disc. That's where the optic nerve comes in, right? That's where the optic nerve comes in. Now here's the thing, there are no rods or cones on the optic disc. So what does that create? A blind spot. We have a little blind spot in our eyes. But the interesting thing about that is because we have binocular vision, which means what? We have two eyes contributing to that. It makes up for that blind spot, and our brain will just fill it in. It's pretty cool. So we don't even realize it's happening. Okay? Optic disc. Okay, good. So those three layers, it's a great picture to study that from. So pupillary constriction and dilation. I want to point one other thing out while we're on this picture. The different humors or the different fluids that are in the eye. I think this has got to be further in the notes. Is it? Good. Okay, good. We'll get to it when we get to it. I think I'm getting too ahead of myself. Constriction, dilation. So dilation with sympathetic facilitation and distant vision, and also things that we like. So next time you're talking to somebody you think's cute, look at their pupils. See if they're dilated. Okay. Okay, you can tell if they like you. Constriction with parasympathetic stimulation, close vision, things we could care less about, so I don't want to see constricted pupils. Okay. So that's just how our system works. And you could see, if you look at the actual muscles that are on the eye itself, you could see that there's different rings of muscles and how the fibers go. There are rings that radiate out like the rays of the sun. There are a ring of muscle which create a circle. So you could see how that circular muscle, when it constricts, it's going to make the eye what? Smaller. When those fibers that radiate out get pulled on or constrict, it'll pull the eye open. Okay, so sympathetic is gonna innervate those fibers that pull out. Parasympathetic will innervate those fibers that are the circular fibers that constrict it in. Okay, that's how we regulate that. Okay, retinal detachment. Oh, there we go, good. So retinal detachment. The retina we saw was pretty flimsy, right? If we have a head trauma, we can actually detach that and take it off of its blood supply. And we've got what's called a vitreous and aqueous humor that are in the eye. We'll talk about what those are like in just a minute. But you can imagine how if that lifts up, fluid can get behind it. If fluid gets behind it, it's going to take it off of its blood supply. That's a bad thing. Nerves love blood supply. If that is not fixed and it's not fixed quickly, the patient will have permanent sight loss. Okay, so this is a bad thing. The pathognomonic sign, pathognomonic means very stereotypical for that disease. The pathognomonic sign for that, guys, is it looks like somebody just pulled a shade across my eye. It has that kind of, and if you can imagine that you're pulling the retina up, you're detaching the retina from its connections, right? That's what happens, okay? It looks like a shade has been pulled across my eye. That is a surgical emergency. Okay. Somehow they use a laser, and that laser helps to push the retina back and they pull the fluid out. I'm not sure exactly how it's done, but it can be fixed. Corneal transplants. Can anybody tell me why these are so easy? Why are corneal transplants so easy? Any guesses? If I cut my skin, what comes out? Blood. If I cut my cornea, what would come out? Fluid. So the cornea does not have a direct what? Doesn't have a direct what? Blood supply. Okay? It doesn't have a direct blood supply. Because it doesn't have a direct blood supply, it doesn't stimulate the immune system. It doesn't stimulate that response to antibodies, okay? Or antigens, I should say. So we can replace corneas easily. When people die, they actually donate their corneas to people. And they'll have them replaced. It's pretty amazing. The cool thing about this little picture here, you can see how cloudy the cornea is on the left. You see how clear the one is on the right. But what else can you see on the right that you can't see on the left? This amazes me. Take a good look. What's in the right picture that's not in the left picture? What? They shouldn't be there. I mean, they should be there for that surgery, but they shouldn't normally be there. They're not lines from a marker. You're on the right track. What are they? Yeah, those are stitches. Isn't that amazing? That somebody could stitch, and look at how many of them there are on there. I know, it's a little freaky, right? But, oh, those are all stitches, okay? Dissolvable, those dissolve over time, okay? I know it's freaky, but when you have something that disconcerting in your life, you're willing. I've had surgery a couple times for pretty big things. You're willing. You know, when you get that bad, you're willing to put up with stuff like that, okay? Because the person on the left, they couldn't see it all, I'm sure. So corneal transplants, so easy because there's not direct blood supply. Oh, here's those internal fluids. Okay, so we've got basically two compartments. In front of the lens, we're going to have the anterior. Behind the lens, there's the posterior, okay? Behind the lens, we're going to have what's called vitreous humor. They call it, I don't know if they call it a segment, a division, I don't care, whatever. I want you to know anterior versus posterior, okay? So behind the lens is going to be that posterior segment, which is where we're going to have vitreous humor, okay? Vitreous humor, guys, is very gelatinous. When we cut open the cow's eyes, you saw it, okay? It was that gel-like structure. You have the same vitreous humor that you were born with. And amazing, you'll have it until you die. It doesn't rejuvenate or regenerate itself. What regenerates itself is the aqueous humor, and that's really important because the aqueous humor is going to provide the nutrients to the inside of the eye. Okay, it's regenerated several times a day, I believe. Okay. It goes through the anterior part in front of the lens. It also goes around that vitreous humor in the back. Okay, so it circulates through the whole eye. It will empty, and I'm not joking, into what's called the Canal of Schlemm. Dr. Schlemm found it and named it after himself. That's what happens with all these crazy names. But it's important to know that that is being emptied. Because if we create this aqueous humor and it can't be emptied from the eye, what's going to happen? So if we create this aqueous humor, but we can't get it out after it's done its job, what's going to happen? What's going to happen to the pressure of the eye? It's going to go up. Okay, this is a bad thing. We'll talk about this in right here. I didn't realize it was the next slide. It's called glaucoma. Have you guys, you're too young. Okay, when they do a glaucoma test, oh no, you guys, I'm sure you've had this one. It's when you put your chin on that little thing at the optometrist. I know, I do too. But wait until you hear what they're doing now. And you put your eye in and it does what? Right? It does that little puff of air. Now, if your eye does not have glaucoma, it'll deform. I don't know the exact numbers. It'll deform a little bit. You'll see, imagine it. Imagine it's like a water balloon and you put a puff of air in a water balloon. It's going to deform a little bit. Okay? So your eye should deform a little bit. If it's not, it could be an indicator of glaucoma. Well, the new thing that they're doing now is they actually have a pressure receptor. It's a machine, and it has a little round portion, and they open up your eye, and they bring it closer and closer and closer until it touches your eyeball. Oh, I hate it. And I went to somebody who had just started doing it, who's like an assistant, and she kept like coming at me with it. And I finally said, I can't, you need to get somebody else to do this. Like, I'm such an impatient patient, as you could probably imagine. And she did, and this woman just came from the side, and it was so much better. But and she kept doing it like that too. I'm like, what? And then the more frustrated she got, the more she came at me, and I was like, not happy with that. But anyway, it is important to sense, because if you have an increase in the pressure of the eye, once again, nerves don't like pressure. It starts to put pressure on your retina, and it can cause blindness. okay? So if you have glaucoma, it needs to be determined and you need to put on medications to decrease that pressure, okay? So increases pressure on the retina and also the optic nerve. I should mention that as well, okay? All right. Let's see. Cataract is clouding of the lens. We talked about this. To replace it, has anybody ever seen, is anybody in clinicals yet? Are you guys on the 4-year, the bachelor's for the most part? Okay. So this is a pretty cool surgery that you'll probably have an opportunity. And they open up the eye and they go in to actually cauterize those suspensory ligaments that we just learned about, take the lens out and replace it. I'm not sure how they support it though. But this is called a cataract when the lens becomes cloudy, but they're also doing it, like I said, for people with visual problems, which personally I'm waiting to do because it makes more sense to me than shaving my cornea. It kind of freaks me out a little bit, you know? So, and, you know, they could replace that again. So, visual disturbances. We have something called, you know what, let's take a little break. I didn't realize it was already 10 of. Let's take a little, oh, perfect. Like a 10-minute break because I'm going to go get a cup of coffee. And then we'll meet back here and we'll finish up the rest of the slides. Do you guys have any questions? Awesome. Great. All right. Let's see. I know I've got another little musical interlude here. Perfect. Let's see if this will let me connect this time. Huh. Interesting. Let me connect this way. God bless you. All right, see you back here in 10 minutes.